working.
Okay. Now, Guru, you'll have to guide me through how do I share my slide here?
Okay, 1 second. I will just, I will just turn off, minimize this schedule stream.
Oh, yeah, share screen here. Okay.
Give me 1 second, Parent. I hope it is live streaming. Yeah, okay, it is live streaming. Now, at the bottom, there is a share. You can see that share screen at the bottom.
Yep, I can see the share screen.
Yeah, click on that.
It says that host has disabled.
Oh, yeah. Oh, give me 1 second. All right. I'll have to make you co-host or something like that. Make co-host. Okay. I think it should be good now. Try again.
Yep.
Share screen.
So I'm doing share screen.
We're all used to so much to the Microsoft Teams, isn't it?
Exactly. Okay, just one second. What I'll have to do is minimize this window and open the PowerPoint on the other screen. So
yeah, when you click on share screen, it will ask which screen, the whole desktop or
yeah. Just 1 second.
Yeah, close all privacy ones.
Yeah.
Meanwhile, I'll just check on YouTube if it is on. Yeah, I can see your screen.
Excellent.
Meanwhile, I'll just check on YouTube. Okay. All right. I think we're still live. Parin, so before you start, I will just share my screen. And so first of all, I would like to thank everyone, can you see my screen now?
Yeah, I can.
Yeah. Look, Dr. Parindora is my very good friend and an endocrinologist who is very closely working with the peri-operative anesthetic team in various aspects, and diabetes is one of them. The main reason to bring you into this was twofold. One is to make people understand the current trends in diabetes management, which is actually affecting our anesthetic care, how we care for our patients with some significant concerns with newer medications. And through this series, over a period of few months, we will be hopeful to cover many more topics so that we as anesthetists can perform much better as peri-op physicians. Not that we don't want to take away your job, or your job will still be there. You can always be useful to guide, but often we do fall in a dilemma where we don't know what to do, how to do. So I just want to go through some of these three things. One, for most users who are members of the Medusis gas platform, Parin, this is the platform we have developed for anesthetists in India through an organization called Global Anesthetic Society, spearheaded by my good friend, Dr. Shiv Kumar Singh, who's based in Liverpool in UK. We are on a Facebook group with more than 30,000 plus anesthetists from across the world. So it's like 24/7 CME going on there, and also, in terms of interactions with not just sharing knowledge and also about caring for each other. So as a part of our ongoing commitment to improve safety and quality in anesthesia, we developed this platform, and members get registered at 3,000 rupees per annum, which is basically nothing. When they do get aspects of complete perioperative care in patient management. And one of the key things is education. So we developed this Medusis e-learning system of
Mhm.
CNME. So where we do conduct all the workshops. We got e-library with all the books, and in this e-library, you can see there are a lot of topics which is all categorized to help quick search. And previously I'd uploaded few articles on diabetes. So this was the French guideline. So this is pretty old, but that was once which was freely available. So it takes through the whole peri-op period, and it looks like not many people have gone through this as often as we would like to. Um, and then there is this conference and workshop, which is what we are doing today, the Peri-operative Endocrinology series. So all the viewers who are members, I would ask them to click on the feedback, and then just quickly go through, give the feedback. Just give me 1 second. Sorry, give me one. Sorry, the dog issues. They're fighting each other. So yeah, if they can give a feedback here, and um, they'll be able to obtain the certificate. So going back, I'll just quickly go through a presentation that I've done.
Mhm.
So basically, we along Medusis is the company that I co-founded with my friend in Bangalore to develop this platform along with the Global Anesthetic Society. So I posted this case scenario recently about 84-year-old, 82-year-old lady with distal radius, or if with a fracture, with multiple comorbidities. And coincidentally, I found that she was not diabetic, but was on dapagliflozin.
Mhm.
So that was a little bouncer for me. Oh, okay. I had some idea that it's a kind of widened use outside of diabetes, but that did worried me. But she had not stopped the dapagliflozin, and it turned out that her ketones was 2.5.
Mhm.
And then I said, oh, what next? So I got in touch. This was in private. So I got in touch with the physician who helps with the surgeon and said, look, we can't do her now. We'll reschedule, and I'll come about this case. But also, I had a couple of previous other two experiences. Now, this is quite common in my experience.
Mhm.
Is that a lot of people with type 2 diabetes, they are on these glyphosins, and they come for colonoscopy and things like that. And in this, often, even if they have stopped, sometimes when we do the ketones, it's very high. More than one is my kind of threshold. It moved up from zero point 0.5, it went up to 1.6. This one, and then this is at a standalone gastro unit. There's nothing much I could do, so I just had to give fluids and recheck again, and kind of, because the patient would have gone through a full bowel prep. You can't postpone them, you can't bring them back again. So sometimes we just bite the bullet and just go ahead and do it. And luckily, nothing happened. But there was this case where a patient was for elective total knee replacement, but patient um, didn't stop. So give me 1 second. Looks like this Zoom has frozen for some reason. Um, I might share and might have to go out and come back again. Um, so because my friend has just logged out. Um, Oh, you're back again. Thanks. Thanks, Parin. I think there was some internet error here.
Sure.
So I was just going through this presentation of mine, and I'll just quickly share again.
Yep.
So I had this total knee replacement with type 2 diabetes on dapagliflozin, and patient only had stopped a day before.
Mhm,
Ketones was 1.2. And, it was kind of a little bit of pressure from the surgeon, I should say, that,
mhm,
look, oh, it's okay, should be good, no good. Patient would have kind of made so many arrangements to get this elective joint replacement.
mm,
So what I did was I just, again, bit the bullet and did the case.
mhm,
And then post-operatively, it started to creep up to go, went up to 2, did an ABG, was acidotic, and yeah, I did hear a few words from the intensivist where I had to take into the intensive care. So I just thought, also looking at the awareness of these SGLT2 inhibitors across many nations, I think currently there are some issues that people are not aware and somehow are getting away with the consequences of not knowing and not seizing it adequately. So
mhm.
what I'll do is I'll stop sharing now, and I will let you take over to discuss these new insights in diabetes management and enlighten all anesthetists so that we can look after our patients in a much better way. Thanks, Paul.
No problem, Guru. Now you have to again make me co-host for me to
Yeah,
be.
that's right. Yeah.
We'll come back to your scenarios eventually, but what I thought I'll do is I'll give a bit of update about diabetes management in 2023. You're absolutely right. This is really a tricky situation in perioperative period when SGLT2 inhibitor is used, and our awareness has increased immensely over last couple of years in management and what are the potential ways around not delaying the surgeries. So just bear with me. I'll open my files and share my slide. 1 second. So during the internet interruption process, it seems like my computer had crashed and I have to open the file again. Can you see my slides or not yet?
Have you started share? Yeah. Okay. Yeah, all good.
Excellent. So just a bit about myself. So I'm an endocrinologist in Adelaide. I work in one of the teaching networks here, and I have been part of the guideline of SGLT2 inhibitor in perioperative phase. There are lots of guidelines being developed over many years, and I must admit that a lot of these guidelines are becoming quickly outdated as new and new medications come in management of diabetes. We have the most up-to-date guideline now, which is prepared by the Australian Diabetes Society. And Guru, I will share a link with you. I might have already done that. So please share with your colleagues. It is quite comprehensive, and it does include most of the scenarios except the GLP-1 agonist, where the information is still quite new about management perioperatively, and there's information paucity there. So this is the holy grail of managing any diabetes. So ultimate goal for endocrinologists or physician is to prevent the diabetes complication. We commonly learn these complications as macrovascular and microvascular. There are lots of acute and chronic complications other than those micro and macrovascular complications, but this is the gist. This is the ultimate holy grail of management of diabetes, the complication prevention and giving quality of life to our patients. So what I'm going to cover today is what is the new information on SGLT2 inhibitor, GLP-1 agonists, and there's a new kid in the block called GLP-1 agonist and GIP receptor agonist. I'll talk about the lifestyle management, which is revolutionizing the diabetes management, particularly the remission of diabetes approach, whereby people don't require any pharmacotherapy and their diabetes is under control. And finally, another revolutionizing diabetes management is the technology advancement, mainly in glucose monitoring, but also in insulin delivering. And this is particularly relevant for people in type 1 diabetes. So talking about the medication management, and I'll talk about mainly SGLT2 inhibitor and GLP-1 agonist. And the reason why is that if you look at the history of diabetes trials, all the studies done in diabetes field before 2008 was glucocentric trials, by which a drug will be compared with a comparator or a placebo, and the outcome is the glucose control or the HbA1c control. So if you look at all the old drugs, metformin, sulfonylurea, glitazones, insulins, acarbose, they were all designed to show the HbA1c improvement and then long-term macro and microvascular complication outcome. And what was found in some of the major studies called ACCORD study, VADT study, an advanced study, which were done in people with diabetes, aiming for tightly controlled diabetes versus less tightly controlled diabetes. And they found no benefit in macrovascular complication prevention when the HbA1c target was very tight. In fact, a ACCORD study showed more macrovascular events in people where the target HbA1c was aimed at below 6.5%. And that's when FDA in the United States came in the picture, saying that, no, we can't just do the glucocentric trial. Any new drug coming in the market has to do cardiovascular trials. And what they said was the new drug has to be studied in people who have a very high risk of diabetes and cardiovascular disease. So those who have diabetes and myocardial infarction, those who have diabetes and peripheral vascular disease, and those people with diabetes and stroke. So if you can prove your safety of your drug in this high-risk population, then you are allowed to be used in the nation. And that's what the FDA mandate was. And what was the benefit of that? All the new drugs after that, which is DPP-4 inhibitor, SGLT2 inhibitor, GLP-1 agonist, and all the new agents subsequently have to do mandatory cardiovascular trial before they are approved for use in people with diabetes. So if you think about SGLT2 inhibitor, the substance called fluorosin, which was discovered in the apple bark tree more than a century ago. And this is now eventually been developed into the medication. Most of your colleagues would know how the SGLT2 inhibitor works, but just going back to the basics, this is the nephron. This is where most of the glucose get absorbed, and then almost all of the glucose gets reabsorbed in the proximal tubule in the S1 segment where the SGLT1 and SGLT2 receptors are located. So physiologically, most of the glucose is reabsorbed, and that's why physiologically you don't see glycosuria. So what SGLT2 inhibitor does is by blocking this enzyme, it tends to stop the reabsorption of glucose and ultimately leads to glycosuria. And with some of the SGLT2 inhibitors, you can get about 70 to 80 grams of glucose loss per urine. So if you go back to the biochemistry lesson, how many grams of glucose equal to calorie comparison? So if everyone knows that 1 gram of glucose or carbohydrate is linked with 4 kilocalorie loss. So people can lose about 320 to 350 calorie per day by using this agent. And that's why this agent can be linked with some weight loss as well. And again, through osmotic process, when the glucose is highly exposed to the nephron and collecting tubules and in the urinary tract, water tends to follow. So when there's a glycosuria, there is some sort of diuresis that happens as well. And based on these two key principles, it has been found to have multiple effects which are positive. So there's a HbA1c reduction as a class effect of SGLT2 inhibitor. There is mild weight reduction. There is a systolic blood pressure reduction. There's NT-proBNP reduction, and then slowing the progression of chronic kidney disease and albuminuria. And what the studies have been found to show with some SGLT2 inhibitors, there's a marked reduction in cardiovascular events, cardiovascular death, and by all SGLT2 inhibitor, reduction in hospitalization from heart failure. So these are all major beneficial effects. And as a result of that, American Diabetes Association, European Diabetes Association, EASD, and the Australian Diabetes Society have now come up with a guideline suggesting that those people with diabetes who have established cardiovascular disease, heart failure, or renal disease should be prescribed SGLT2 inhibitor as a second-line agent after metformin being the first-line treatment. So we're using these agents more and more frequently. And some of these studies, which I've mentioned before, is summarized here in meta-analysis done and published in JAMA 2 years ago. So on the left side, you can see EMPA-REG outcome. EMPA-REG was empagliflozin, 2 different doses of empagliflozin, 10 milligrams and 25 milligrams against placebo. And placebo was still using metformin, insulin, and whichever kind of basic treatment people were able to use to control the HbA1c. So there was no HbA1c target here. Both the groups could have same HbA1c target if the physician chose to. The other group was just having additional empagliflozin. And yet, as you can see, the hazard ratio 0.62, meaning 38% reduction in cardiovascular events or major adverse cardiovascular events compared to the placebo group, which is something that was never heard of in people with diabetes using diabetes medication. To give you a perspective, if you use statin, when the statin studies came out, it showed relative risk reduction of about 35 to 40%. And then this is equal to that, despite people using statins, ACE inhibitors, and other already proven cardiovascular drugs. And other studies, as you can see here, CANVAS using canagliflozin, DECLARE using dapagliflozin, CREDENCE was a study using canagliflozin in particularly the stage 3, stage 4 kidney disease people, VERTIS, which is sotagliflozin. These trials have overall shown, as you can see from the star here, marked reduction in the cardiovascular death. And then they had broken down this agent into those who had established atherosclerotic cardiovascular disease and those without atherosclerotic cardiovascular disease, just high risks. And overall found that those with established cardiovascular disease and atherosclerotic cardiovascular disease status, patients actually had a better outcome using the SGLT2 inhibitor. So that was a cardiovascular death. And then they looked at the hospitalization from heart failure. So heart failure is a problem because people with diabetes often end up in the hospital, occupy hospital beds, and hospital occupancy is a major burden to the healthcare system. And as a class effect, all these agents showed marked reduction in hospitalization from heart failure. And it is something very unique to this class of drug, and that's why it has been now established, even in people without diabetes, as one of the top line agents. These were the renal outcomes of those patients with diabetes who had established renal disease. And overall, overwhelmingly, it showed reduction in progression of chronic kidney disease or even reduction in albuminuria. And subsequently, studies using SGLT2 inhibitors in people without diabetes with chronic kidney disease have shown very similar outcome. And that's why some of the SGLT2 inhibitors, such as dapagliflozin in Australia, is now approved by the government to be used in kidney disease. So Guru, what we will find now is that these agents will not only be used for people with diabetes, but also in people with heart failure with or without diabetes, and in people with chronic kidney disease with or without diabetes. So I think we just need to be aware of its use. Now, the side effects are mainly genital thrush that happens mainly in women, but can also happen in men. So we must educate all our patients about this side effect. And the other documented side effects, such as urinary tract infection, volume depletion, hypertension, in my clinical practice, I haven't found them as a major barrier or major problem, people coming and asking me about these side effects. But genital thrush is definitely a common side effect. And as mentioned before, the other emerging side effect has come out is euglycemic ketoacidosis. So pure from definition point of view, euglycemic ketoacidosis is defined as euglycemia, which is glucose less than 14 millimoles per liter. That in milligram per deciliter would be somewhere around, let's say 200 to 230 milligrams per deciliter. Ketones of more than 1, and base excess of less than -5. In a simple term, for people who don't have access to ketones and base excess, BBG or ABG, you can look at the other blood tests and can get a clue whether patients are at risk of ketoacidosis. So people with bicarb of less than 15, or people with high anion gap because of mainly ketones, you can identify those patients at risk, or those who already have ketoacidosis. So Australian Diabetes Society and New Zealand Society of Diabetes had put the alert in 2020 about this potential association. And then since then, we have been using these guidelines in our local practice to make everyone aware involved in the diabetes care, including patients and the clinicians. So these recommendations mention that the patients must be informed by prescribers about the use of SGLT2 inhibitors. Patients must be explained the symptoms of diabetic ketoacidosis, mainly involving abdominal pain, nausea, vomiting, fatigue, and in extreme cases, shortness of breath. There's a general advice should be given to the patients to stop SGLT2 inhibitors 3 days pre-procedure. That means 2 days before and the day of procedure, or in acute illness when patients get gastroenteritis, sepsis, or fever, or generally when they have significant illness, reducing their oral food intake or fluid intake. There's a high association of this risk of euglycemic ketoacidosis when people have insulin deficiency. So if you look at people with HbA1c of more than 9%, it gives you a clue that these patients may have endogenous insulin deficiency. And these patients, particularly if they haven't stopped the SGLT2 inhibitors, could be at high risk of developing it. We have often found that people with type 1 diabetes are unmasked. So we were treating these patients as type 2 diabetes all these years, and suddenly they get euglycemic ketoacidosis. We send them for type 1 antibodies and find that they're actually type 1 diabetes. So these are the guidelines, which states that at any point during or after procedure, if ketones are more than 1 and base excess is less than -5 millimoles per liter, should be treated in urgent facility. That could mean ICU, HDU, or whichever acute care facility any hospital has. And this management should be done in collaboration with preferably endocrinology team, or if you don't have endocrinology team, then at least with peri-operative general medicine team. This is the table of management of people who are clinically appear well, and then those who have not stopped their SGLT2 inhibitors. So they've come to your anesthesia clinic, and you've done the blood gas on them, and you find ketones are less than 1 and base excess is more than -5, which means there is no evidence of ketosis or metabolic acidosis. These patients can proceed with the day surgery, but because they haven't stopped SGLT2 inhibitor, they still remain at risk of developing it later on. And hence the monitoring post-procedure is quite important to carry out. And this is something that should be informed to the surgical team or medical team in combination with the surgical team to manage this post-operatively. And if you've done the gas and ketones are more than 1, but the base excess is still greater than -5, which means that patients have ketosis but haven't developed metabolic acidosis yet, which sounds like one of your the 2 cases that one of the 3 cases that you had mentioned. These patients you should seek advice from endocrinology or general medicine. If the ketosis without acidosis is because of the prolonged fasting or illness by which patients are still starving and haven't had adequate oral intake, and in those patients who have HbA1c of less than 9%, meaning that they have got enough endogenous insulin, you could still consider proceeding with the procedure, but you could and should use the insulin and glucose infusion intraoperatively, perioperatively, especially postoperatively. And those patients with high ketones and low base excess, confirming ketosis with metabolic acidosis, all the elective procedures should be ideally postponed. And in these patients, medical care should be optimized, SGLT2 inhibitor should be stopped, and then we should proceed with a suitable date for procedure. The ultimate key points of management of euglycemic ketoacidosis are early diagnosis is the key. And once you've done volume expansion with crystalloid, the most important fluid is dextrose. There's a debate going on and studies underway to show the effect of 5% dextrose versus 10% dextrose. It may be that 10% dextrose is better choice than 5% dextrose. And then this fluid, obviously, if used without insulin, could cause hyperglycemia. So insulin also should be used, which also has effect in correcting the acidosis. Insulin infusion must not be delayed or avoided, even if the glucose level is normal. And that is another important thing to remember. We should not be fooled by normal appearing glucose when there is already a ketoacidosis happen to the patient. So that's mainly about the SGLT2 inhibitors. Then I'll move on to GLP-1 agonists. GLP-1 agonist again has a history. It was this funny looking lizard called Gila monster. It's spelled Gila, but it's pronounced as Gila, which is found in Arizona and New Mexico in United States. And one of the interesting thing about this lizard is that it only eats 2 or 3 times in a year. And when the scientists did the study, they found the incretin exuding substance in their saliva, which was then used in the scientific lab to make this hormone called incretin hormone. They're called incretin hormone because they increase secretion of insulin. There are 2 human incretin hormones, glucose-dependent insulinotropic polypeptide, GIP, and glucagon-like polypeptide, or glucagon-like peptide, GLP-1. And their effects in human is, first of all, they're secreted only on food ingestion. And then after their release, they increase the insulin release in a glucose-dependent manner. So they release the insulin from beta cells only postprandially, and that's why it almost never causes hypoglycemia on its own. And then it only controls the glucose level mainly with the postprandial effect it has. It also reduces the glucagon secretion postprandially. And as we all know, glucagon is counter-regulatory hormone, which increases the gluconeogenesis and glycogenolysis to cause increased glucose levels. So if you have suppressed glucagon, you have less gluconeogenesis, and combined effect of these 2 things lower the glucose level. It also helps in gastric emptying by delaying it. And it also has effect on satiety and reduces appetite, hence its effects in weight loss. And then most of your colleagues would know that the weight loss effect with the GLP-1 agonists are quite significant. So the main positive effects of these agents are HbA1c reduction, weight reduction, and positive cardiovascular results. The main side effects are gastrointestinal. Nausea is a common side effect, happens in about 20 to 40% people looking at different studies. Occasionally, it can lead to vomiting. Diarrhea or constipation either could happen. And abdominal cramps or feeling of bloating or feeling of fullness is also one of the side effects. This is the study showing once weekly semaglutide compared with placebo on its effect on the weight. And you can see the effect on the weight is quite huge, causing about 5 to 10% body mass, body weight reduction. These are all the studies in using as GLP-1 agonists, again done in high-risk population with those with established cardiovascular disease. And if you look at the meta-analysis of this in the green here, overall, the effect is quite favorable in reducing the cardiovascular events in people with diabetes. It also reduces cardiovascular mortality. So again, as a class effect, you can see the reduction in cardiovascular mortality. Different agents have different outcome on this, and then particularly pointing out the LEADER study up here, PIONEER study, and then somewhat using we SUSTAIN 6 also is the semaglutide, so or commonly used agents. Quite interestingly, the effect on non-fatal stroke was even more significant, and then this is why we believe that the effect of GLP-1 agonists on cardiovascular reduction, mortality reduction, is through atherosclerotic reduction effects. So that's why ADA recommends that if you think that patients have atherosclerotic cardiovascular disease, you should use either SGLT2 inhibitor or GLP-1 agonist. And if you're suspecting mainly heart failure, renal disease, you should be using SGLT2 inhibitors. They also have favorable endpoints in renal and heart failure field, but they have yet to do the studies in people with purely just renal disease and heart failure. So the perioperative management of GLP-1 agonists, is actually really lack of data, lack of evidence here. There's only one guideline which has come up with some information, which is the American Society of Anesthesiologists. And then what they've suggested is that a day or days before the procedure, for those patients who are taking daily injection of GLP-1 agonist, they should hold it on the day of procedure. Now, I must admit that these daily injections are no longer available in Australia, so we don't use them anymore. The weekly GLP-1 agonist, the advice is to hold it a week before, and monitor the blood glucose, as some patients may require to escalate the other anti-diabetes treatment because they could become hyperglycemic. On the day of procedure, if the GI symptoms are there, you should consider delaying the elective surgery. So mainly the nausea, vomiting, diarrhea, or constipation. Sorry, not the constipation, but mainly nausea, vomiting, and diarrhea. So when there are major GI symptoms, you should consider delaying the surgery. If there is no GI symptoms, then proceed as usual. If there is no GI symptoms, but the GLP-1 agonist was not withheld, then you should consider evaluating gastric volume by doing an ultrasound. Now, I've spoken to my colleagues, gastroenterologists, anesthetists, endocrinologists, and none of us do this gastric volume by ultrasound perioperatively. But this is one of the guidelines that Americans have come up with. There is no separate fasting guidelines whether the patients should fast for longer or not. So again, there's just lack of evidence in how we manage these patients on GLP-1 agonists. So as it goes at the moment, if possible, a week before your procedure, you could stop the dose. And even if you haven't stopped the dose, if patients don't have any GI symptoms, you could potentially still proceed. But if patients have GI symptoms, and if possible, you should delay the surgery. And finally, I'll run through this, the newest agent, which is going to be available in Australia very soon, not on PBS. So it's a very expensive medication using GLP-1 and GIP receptor agonists combined, which is interesting because when people have used only the GIP receptor agonist in management of diabetes, it didn't have favorable outcome, and that's why people had lost interest in studying this drug on its own. But when combining with GLP-1 receptor agonists, pretty much you get the same effects and side effects as you would expect with GLP-1 agonist, except the additional increase in lipogenesis, which is probably counteracted by the lipolysis done by GLP-1. So the New England Journal Medicine article was published not so long ago, which compared this new agent, terziparatide, with established drug, which is semaglutide 1 milligram. And terziparatide, they use 5 milligrams, 10 milligrams, and 15 milligrams doses. And you can see that at any of these doses, it had better result compared with semaglutide in the change of the HbA1c, and even better result in terms of weight reduction compared with semaglutide 1 milligrams. So Guru, what's going to become a new trend is using these agents more and more commonly because of its significant effect in both diabetes and also in weight loss. But really the price is a big barrier at the moment. So this is mainly the drug that I wanted to talk about. I'll move on to the lifestyle management, which is revolutionizing the diabetes management. And I wanted to particularly focus on diabetes remission approach. And the reason why I wanted to mention is this study called Direct Study, which was done in UK. And then you can see there are only 306 number of people recruited in this study. But the beauty of this study was done at the primary care level. So not in the trial unit, not at the trial level in the tertiary center, but it was done at the primary care. And what they had done was 12 weeks of very low calorie diet for newly diagnosed people with diabetes, followed by gradual reintroduction of food, and then mainly aiming for weight management. And what they found was nearly half of the people at 1 year, when they did the HbA1c, they were in diabetes remission. I'll go through the definition in the next slide. And even at 2 years' time, 36% patients did not have diabetes without any medication treatment. And these similar studies have been done in Middle East, in Diadem study, using similar sort of concept of meal replacement, followed by gradual reintroduction of healthy food. And there's also a ketogenic diet study done in United States, which didn't have as impressive result of 50 to 60% remission, but still 25% diabetes remission. So diabetes remission is defined as HbA1c below 6.5% without medication. It should be discussed and considered at diagnosis, and most benefit are seen in first year. And there's growing interest and some evidence. And then I can tell you from Australian experience, some of the centers have started using this approach. What we find is what really works is ultimately 7 to 10% of weight loss. So argument sometimes we make is, if you can achieve this through lifestyle alone, and if you happen to be on metformin or SGLT2 inhibitors or GLP-1 agonists, what difference does it make? You can just call it pharmacological remission. But the goal is to get some form of remission of diabetes, because that's physiological. Anything more than 6.5% is diabetes. Anything less than 6.5% is not diabetes. And we shouldn't be aiming for any higher HbA1c for newly diagnosed people with diabetes. And of course, the dietitian supervision is important, and not achieving remission is not a failure. So it's really important that we tell our patients with diabetes, that it's not a failure. We can try another way, which is pharmacotherapy. And I'll quickly go through this exercise update on Royal Australian College of General Practitioner. We all know that the recommended exercise, if you look at any heart association, diabetes association around the world, would recommend most days we should do some aerobic exercise. We should do 150 minutes of exercise per week, and we should be doing moderate to vigorous intensity exercise. But when we ask our patients with diabetes, what does it mean for you when we recommend these sort of intense exercise? And they actually don't know the definition of moderate exercise, or they don't know the definition of vigorous exercise. Similarly, if you mention about the anaerobic exercise, it is recommended 2 to 3 times a week, at least 60 minutes a week. But again, we don't clearly define this in our recommendation to our patients. So just going to the gym and lifting some weight is not just anaerobic exercise. It needs to be tailored at the appropriate muscle group in a safe manner. And the third most important exercise is balance and flexibility. Now, these are the general guidelines for cardiovascular benefit and incidental exercise, of course. I'll go through these two evidence in exercise. One is American College of Sports Medicine, and the second one is Exercise and Sports Science in Australia, which is what we generally tend to follow. And this is where the definition of sedentary, light exercise, moderate exercise, vigorous exercise, and high intensity exercises come. And just to cut to the chase, I really like the descriptive measures on the rightmost column. So an exercise that is conducted in, excuse me, while you can still maintain the conversation uninterrupted, is defined as moderate exercise. And an exercise where you can't even maintain the conversation, is defined as vigorous exercise. You can keep it as simple as that to your patients. If you want to go more in detail in scientific manner, you have got your VO2 max or maximum heart rate, and then you can measure those things based on those parameters. This was a study done showing physical activity in management of obesity in adults. And this is a position statement by the Exercise and Sports Science in Australia. This is not necessarily all people with diabetes, but people with obesity. And what they found was, for meaningful weight and total adiposity loss, a minimum of 300 to 420 minutes of exercise per week is required, of at least moderate intensity. So roughly 1 hour a day. And once you've achieved your target weight, then 150 to 300 minutes of exercise per week is required to maintain that lost weight. So otherwise, people tend to regain the weight. So it's really important to mention this is the evidence. And again, this is not a high quality evidence. This is a moderate quality evidence, but this is the information that we have found so far after many, many, many studies done on exercise and obesity. So my take is that keep it simple when you're describing these lifestyle measures to your patients. Be persistent in a non-judgmental manner. The last thing your patients want to know from you after hearing from everybody else in their life and hearing their own mind is you telling off for their weight gain. So know the lifestyle of your patients before you even give your advice to your patients. Find out what the barriers are. Find out what patients like, what they dislike. Focus on the low glycemic index carbohydrates and healthy fat. So if they can't do the diabetes remission, that's not the end of it. You can still advise on a low GI carb and then healthy fat. You should discuss the strategies to avoid bad triggers to manage them. For example, Guru, you and I, when we are in a bad mood, we sit down on the tape in front of TV and start eating something. And that sort of trigger, what is the association you can minimize? So if I didn't watch Netflix at the end of the day, probably I wouldn't be eating those unhealthy snack. Focus on regular exercise and activities. And ultimately, what we've learned in diabetes particularly, what works is 5 to 10% of the weight loss. And finally, I wanted to cover the technologies which is revolutionizing the diabetes management. What's happening, particularly for type 1 diabetes in Australia, is they can all get access through the government scheme using continuous glucose monitoring and flash glucose monitoring, whereby people don't have to prick their finger to check the blood glucose. And you get blood glucose levels every 5 minutes for 24 hours, which gives us very good insight into the glycemic trend and also the lifestyle. And then the other technology advancement is in hybrid closed loop pumps. So these are the insulin pumps delivering insulin, and they are learning from the continuous glucose monitoring devices what the glucose level of the patient is, and then able to deliver more or less insulin on a minute-by-minute basis, which is really mind-boggling because it is really a step closer to the artificial pancreas. So this is the picture of Freestyle Libre, which is a flash glucometer, where a patient with diabetes wears a sensor on their arm, and you can either use your phone app or a glucose monitoring device to scan your glucose to know your blood glucose level. And you can get these glucose readings continuously. The principle it works on is the interstitial fluid. So you all know that capillary glucose is the blood glucose level, whereas these devices sit under skin and they rely on the interstitial fluid. And then the interstitial fluid also has a glucose, which through algorithm they have worked out how it compares with the plasma glucose, and it pretty much gives you the reading which is synonymous to the plasma glucose level. The beauty of this device is that not only gives you the blood glucose in live time, but it also predicts that where is your glucose heading in next few hours, knowing the trend, what has happened before, and predicting what's going to happen in future, which is really helping our people with diabetes who are at risk of hypoglycemia, because if the glucose is low, and if they're getting a downward arrow, which gives them a clue that in the next few minutes, I'm going to get a low glucose unless I eat something. So it's in prevention of hypoglycemia, it's very important. And similarly, people with high glucose level, when they have an upward trend, if they have got a plate of cake sitting in front of them, they're probably going to avoid eating that cake knowing that their glucose is heading up anyway. So it's changing the lifestyle in a way, giving them biofeedback on a continuous basis. So when people use these devices, we get a report like this, which is we call an ambulatory glucose profile. And then to non-endocrinologists, I explain them this is like a reading an ECG for cardiologists. This is a reading a glucose 24-hour profile for our people with diabetes. And then we can find out where the glucose trend is, what is the mean glucose level, which time of the day where they are highly likely to get hypo or hyperglycemia. And then we get this more extensive report, which I tell it's an echocardiogram report by the cardiologist. So on the top left, you get 14 days profile, how many time people are using this continuous glucose profile, what is their average glucose, what is the estimated HbA1c or GMI. On the top right, you get the breakdown of how many times they spend time in normal glucose or high glucose or low glucose. So if you think about for a cardiologist, the most important thing is what is the ejection fraction. So for endocrinologists, the most important thing is what is the time range, so target range of the glucose. And that is equal to the, it's sort of synonymous to the HbA1c. So people with more than 70% time in range have a HbA1c, which is less than 7%. And the reason why this is important is that if you look at these three examples, all three examples have HbA1c of 7%. On the right side, you can see that HbA1c with 7% has a glucose all within the normal range. On the middle one, you have a glucose which is 70% in normal, 25% high glucose, and then 5% low glucose. Whereas on the leftmost side, this person is having hyperglycemia, hypoglycemia, and euglycemia all the time, huge fluctuation in glucose level. This is something we were not able to find out just based on the HbA1c. And this is something we can now find out using these sort of glucose monitoring devices. And this is the insulin pump that I've mentioned before. So these insulin pumps sit subcutaneously and then through the Bluetooth or a different EFT technology, they can transfer the data between the continuous glucose monitoring and pump and deliver the insulin. So that's the bit that I wanted to go through, Guru, about the update in diabetes management in 2023. I'll hand it back to you now.
Thank you very much, Parin. It was extremely insightful, especially nowadays we are encountering all these kinds and patient on insulin pump, and often I ask them, can you show me how to use this device? Then they'll show me like you press this and things like that, whether to continue basal and basal insulin pump keep going on, whether to stop it or not, or intraoperatively when the patient is unconscious, how do I control? How do I give an extra bolus through the pump and things like that? So that knowledge of the pump is important. So often I've spent 5-10 minutes with the patient before taking them under the anesthetic, how to manage this thing. And if you can stop sharing now, I'll just, what we can do is, I've got a couple of questions coming through.
Yep.
Thanks for your time. I think it's any time that your wife and kids will be home soon. And thank you very much for in short notice you've been able to put up some time. Because this is the first of the series, and I'm going to be honest that I will trouble you again, of course, with more information. So, for example, how to manage a patient on an insulin pump perioperatively, So I think our focus in the next few months will be on diabetes, perioperative management, and I really appreciate your time giving us so much insight into this SGLT2 inhibitors, because we don't know, to be honest. A lot of us don't know how it works, how useful it is. In fact, in the community side, we know it is very good agent. But as anesthetist, we actually hate it. But we need to kind of embrace that now, that we need to learn to love that drug for what it does to our patients on the long run, but carefully managing this.
Mhm.
So my first question is, like, for example, in that colonoscopy patient, it was a standalone colonoscopy unit,
Mhm.
no gadgetry, nothing. It's just they just do colonoscopy. So we
Mhm.
don't have any ABG machines.
Mhm.
Okay. Unfortunately, I think one of the patients was not communicated. This was about a year ago or so, where there was a little bit of less insight. In fact, we've gone to the other extreme, that the nurses are just calling them and asking to stop the gliptins also, because Jardians, Janumet, they are getting confused all over the place. So even the gliptins are getting stopped 3 days prior. Anyway, and they do ketones for the gliptins too. So I don't mind, I'm not trying to correct them, but it's just this patient had 1.2, 1.4, and we have no facility to manage, or find out whether the patient is acidotic or not.
Mhm.
Patient was symptomatic a little bit. Often colonoscopy patient, they blame it on the dehydration, and that horrendous nausea feeling from the prep itself.
Correct.
the,
Yes.
they're already in a bad shape, and this kind of is kind of tipping them off the cliff.
Mhm.
So in that scenario,
Mhm.
how should I manage?
So, Guru, in an ideal world, if your patients have symptoms, you have to assume they've got a ketoacidosis, and you have to delay the procedure. So,
mm,
colonoscopy is, in most situations, not a life-saving procedure. It's not an emergency
so
procedure, right? So, I think we should delay when they have symptoms. But your patient had very mild ketones.
yeah,
So, if they didn't have a symptom, I would still suggest, if you should do the blood gas, because they can tip into ketoacidosis anytime.
yep,
Um, so and colonoscopy is one of the situations we have a triple whammy going on. People are fasting, plus they are taking substance to make them really dehydrated, and plus they're continuing SGLT2 inhibitors. It's a perfect storm for something
yeah.
to happen.
That's
Um,
right. It's a common thing, honestly,
yeah,
nowadays.
yeah,
Even if they have stopped, we are now having patients with ketones more than one. You
yes,
know, so that was one case where I just bit the bullet, got the patient, I gave the patient a liter of fluid, just
yeah,
normal saline, just
mhm,
because often the patient are just crooked by the prep itself,
yes,
forget the
yes,
medication. So I thought, okay, look, let's hydrate the patient first, give a liter and check the ketones again. It had come down by 0.2. So from 1.2, it came down to 1.
yeah,
So then I had a chat with the gastroenterologist. We said, look, we'll go ahead, we'll keep measuring.
yeah.
And if it creeps up, we will call Lalmak Hospital and transfer the patient to you. So
So, Guru,
that
if you
was the
don't do,
plan.
if you can't do the blood gas, at least do the bloods,
Yeah,
because then you can send it to the lab and you can get a sense what's the bicarb and anion gap.
yeah,
So by the time your procedure is finished, and if you get those blood results back showing
yeah.
the bicarb is normal and the anion
Yeah.
gap is only mildly raised, at least you're not in a big trouble.
So,
And then don't forget the importance of giving them glucose. Glucose is a key because often they get
yeah.
starvation ketosis. So
Hmm.
glucose helps, provided that previous HbA1c was not very high.
Not very high. Yeah. Starvation ketosis is also. Now, another question, this could be probably been true from where we practice about a year or so ago, but will be true in a lot of places where a lot of my friends work in India, right? Where bedside ketone analysis doesn't exist. All
Mm.
right. The best we can achieve is dipstick, urine dipstick ketones
Yep.
and urine dipstick glucose.
Yep.
Now, is there a surrogate measure
Yeah.
that can be done using the urine values
Yes.
to kind of predict the blood ketones or urinary ketones?
Yes, there is. So,
Mm.
I look, the urine ketones still exist here in Australia, and then they come with plus, 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 or plus, plus, plus
Yeah,
readings.
Yeah.
So we ideally want no plus. That is the best. We know that they don't have ketones. And 1 plus, we have to assume there's a mild ketosis. Double plus, moderate ketosis, and 3 plus is alarm bells for diabetic ketoacidosis.
Yeah. Now, in terms of glucosuria, look, I just realized, the SGLT2 can produce glucosuria, right?
Yep. Mm.
And one of the common tendency in India is also to measure urinary glucose as kind of a surrogate measure of diabetes.
Diabetes
Am I
control.
right? Yeah.
Yeah.
They
Look.
just randomly keep measuring urine glucose, urine this thing.
Yeah.
So would these patients be kind of mislabeled as, still
Yeah.
bad diabetes because their urine
Correct.
glucose is too high?
Yes. So they would be mislabeled. So on SGLT2 inhibitors, urine glucose actually reduces its value in assessing the glycemic control.
Okay. So I think hopefully those who are watching and who will be watching later on the YouTube recording will have this awareness of SGLT2
Yeah.
inhibitors. And that was a beautiful um, graphic representation, which makes it much more clear. Thank you. I mean, there will be more questions coming in, so I will be bothering you in the next few days as I go through some of the questions on the YouTube channel, because I didn't turn on the YouTube here because I think it will kind of bring us into a situation where let me check because the sound here may become.
Yep.
Just give me 1 second. Let me check if there are any questions here straight away. I'll go to the channel and just find out if there are any questions coming through. Okay, just give me 1 second. Now, I'm just also going to share in a moment, I will share this. Give me 1 second. This is not opening here. Come on. I'll have to share the links that you have provided me. I'll be sharing it on my Medusis app also. I'm just trying to open the YouTube to find out if there are any questions. Meanwhile, I've got one more question. Now, GLP-1 agonist. Now, that's the biggest fashion here in the last couple of years, isn't it? It's become a kind of from TikTok sensation to now, right? It's become a big sensation now. So I'm just checking. Give me 1 second. No, there are a few questions on this. Sorry, hang on. Okay, just checking. Okay. There is one question by my friend from Dheeraj. He says about SGLT2I inhibitors. So before we go on to the GLP-1, I'll just clear this off. When he says, do you mean base excess greater than -5, meaning it should be -5 or worse?
So greater than -5 is better than -5. So -4, -3, so on. So that means
yeah. Greater than means more closer towards 0.
More towards normal, yeah.
Yeah, and that is better. Okay. He's got another question. Do you routinely monitor ketones for patients on SGLT2 inhibitors in your practice?
No, so we don't. Not on a day-to-day life. So we ask patients to be aware of the symptoms. Often the people who use SGLT2 inhibitors are type 2 diabetes people, so they don't even have this sick day management of having ketone measuring machine. So we do mention if you can afford, just go and buy it, but at least be aware of the symptoms. And then when they have symptoms, then go ahead and speak to the local doctor or anesthetist or wherever they go for the procedure to get their ketones checked there. Yeah. But it's a good point. So, if you can afford, why not?
Yeah. No, but definitely in the peri-operative practice, we will be measuring ketones for everyone.
Yeah.
So that's pretty much become like, almost because of quite a few cancellations and much to the angst of the surgeons, and now it's kind of become a routine practice across in all the hospitals where I go, the moment the patient says type 2 diabetes, whether they are on SGLT2I, whether they are on the gliptins, whether they just do both sugar and ketones, and if they're not done, I definitely ask for a ketone, full stop. I have burnt my finger a couple of times, so no more. Luckily, there was no major patient harm. So one of the patients, I'll talk to you, I'll go back to the slide that I had. Now, going back to this question, I will close my YouTube and I'll come back to this. So now, going back to this question on GLP-1 agonist, the semaglutide, it's become a TikTok sensation. As you know, it became a lot of a celebrity usage for weight loss. And we ran out of it for quite a few months. And a lot of true diabetic patients were missing on it. And diabetic overweight patients. And I do couple of bariatric places, and I've seen a lot of patients on, semaglutide. And I went through, talking to a lot of these patients, and they said they've almost always developed some tolerance to the side effects. They've been started on 0.25, 1, and, up to going up to 1.25 to 0.5 to 1 milligram per week.
Yes.
And they said this nausea and constipation or diarrhea, it was all kind of almost gone by that time, and the weight loss stabilized. Do you think the gastric emptying also would have probably normalized, or they would have developed tolerance to that symptom also?
Good question, Guru. And I don't know the real answer, because you have to follow a patient's journey longitudinally to assess this in a number of people. And I'm not sure about any study which has done that. I know that the symptoms definitely stabilize over the time. And then you would intuitively think that the gastric emptying also improves over the time, but there's no longitudinal study involving number of people to show that.
Yeah, I was working with one of the GP who's got special interest in bariatric, who's also an assistant to the surgeon. He was telling that often, if you really encounter somebody with GLP-1 agonist, who might come up for surgery, you give them metoclopramide, pre-operatively, maybe 1 or 2 doses if you've got enough time, or at least even 1 dose, So I don't know the benefit of metoclopramide, whether it would actually immediately enhance the...
Again, complete lack of data there. It's just very intuitively use a prokinetic agent, but there's no evidence in that.
Okay, that's true. Again, we are all waiting for those evidences. Now, I think the American Society, the Australian, and as you said, there are newer guidelines coming up very soon, and you are developing guidelines for our Nalan network, isn't it? Along with the anesthetists for this use. And nowadays, bedside ultrasonography has picked up quite a bit back home in India also. This skill is quite, kind of emerging quite exponentially. So gastric ultrasound has almost become bedside now, and probably this would be the silver lining. This drug might be the silver lining for more anesthetists encompassing this, bedside ultrasound skills, and using that to assess the gastric content and things like that. Thank you very much. Your talk went through really well through, medication management, through lifestyle and remission, and the technology that has come through. And it is quite insightful to me, myself as a diabetic. I can look forward to some more knowledge now, and kind of, you talked about Netflix, you talked about food. I think I will have to rethink about my strategies and think about the exercise protocol. So I made notes, 300 minutes. So 300 minutes of exercise and diet. I think that will be trick. So hopefully, look, thank you very much. I'll be troubling you again in doing more parts in this series, including on insulin pumps and, in the pre-operative phase and post-operative phase. Thank you very much. Have a very good night, Pari.
No problem.